guys for being here. I was worried for a little while this morning that I was going to be late, so don't mind at all if anybody walks in after. That's great. That's welcome. Thank you. I really appreciate you guys being here. If I could poll you quickly, raise your hand if you've been to an Operation Naloxone training. Okay, so a lot of people, but we'll keep it open-ended, so I might keep those pieces brief. But as Lori mentioned, I'm a clinical faculty member in the College of Pharmacy, and my research and practice focuses heavily on harm reduction and specifically on opioid overdose prevention. And working in this pop-up is really the first time that I've been emphasizing or learning more about the youth aspect of that. So I'm going to try to couch that in a little bit of data. You'll see that I like to be evidence-based and use a lot of figures and graphs to get across key points. So we'll try to keep it focused in that direction. So I suspect nobody in the room is shocked that we have a drug problem in the United States. You've probably heard on the news talking about the fact that drug overdoses have surpassed motor vehicle crashes as the leading cause of injury death in the United States. And if you look at long-term trends with all drug overdose deaths on this green line and motor vehicle crash deaths with the blue line, you can see cars are getting safer and drugs are becoming more dangerous. And if you came to one of our guest talks earlier this week, you know that part of that is related to fentanyl, and we'll talk about that too. Now, this has been driven mostly by opioids. Opioids account for almost 2/3 of all drug overdose deaths in the U.S., and usually there are multiple drugs present in someone's body when they die from a drug overdose. But the one that is generally the tipping point is an opioid. So opioids plus anxiety medicines like benzodiazepines or plus alcohol are extremely dangerous, but opioids are more likely to kind of push things over the edge than are alcohol or benzodiazepines themselves. Now, our country has done a relatively good job of trying to prevent drug overdoses from prescription opioids recently. These really exploded between 2000 and 2010, but they started to level off after that, and at least the growth recently in overdose deaths due to prescription opioids has been slower. What are some reasons you guys may have heard of in the Pop-Up Institute or are familiar with for why that number might have plateaued a bit or slowed down?
More states using prescription management.
Okay, so these databases that prescribers and pharmacists can search to find out what controlled substances a person has had dispensed in the last 6 months or a year. Try to crack down on people skipping around to emergency rooms to get access to opioids. What else?
They're making it more difficult to prescribe, making it all of them triplicates.
So increased controls on controlled substance prescribing, moving more substances like hydrocodone to Schedule II, which has very specific requirements, doesn't allow for extra refills or calling it in on the phone. So exactly. What else?
Just updated CDC guidelines about the amount you can prescribe at the time.
The CDC guidelines recommended some rational approaches to limit the daily milligram equivalents of opioids, and they recommended those really as tentative, hey, clinicians, make your own choice sort of guidelines, but there are some states and some insurers that have started to enforce those and say, if you're going to prescribe more than 90 milligram morphine equivalents per day, you're going to have to call in and go through a cumbersome approval process. Which may or may not be a good thing, but I'll leave that open. And then there's one other thing that the College of Pharmacy is really proud of, the development of crush-resistant OxyContin. And that actually hit the market in 2010. So you can see that's almost the inflection point. So prescription monitoring programs are increasing, awareness of the overdose epidemic and changes in prescribing are changing over time, and controls are increasing. Crush-resistant OxyContin hits the market in 2010.
You said pharmacy's proud of it. Did that come out of Texas Pharmacy?
Yes, the UT College of Pharmacy, their professor there developed it.
Okay, I didn't know that. That's good.
That technology was implemented in both OxyContin and in Opana ER. We'll come back to that. So I'm going to embarrass the College of Pharmacy a little bit and say that intervention, along with some others, had unintended public health consequences. In the 3 years that followed, heroin overdoses more than tripled, and the net public health impact is that more people were dying from opioid overdoses than would have been projected without any of those interventions. And this isn't, in my opinion, an argument against prescription monitoring programs or tamper-resistant opioid formulations, but it points out that putting in those changes in the absence of broad, on-demand access to methadone, to buprenorphine, to syringe access programs, to supervised consumption facilities, to progressive harm reduction interventions. Without those things, when you cut off an opioid supply, you push people to an illicit opioid market, period. There have also been a number of regulations to crack down on predatory pain clinics, places that would give a prescription for an opioid for literally anything. Many of those have been shuttered, especially in the Southeast in the past 5-6 years. But when they get closed, nothing happens. A methadone or buprenorphine clinic doesn't pop up in their place. And at least from anecdotal reports, most primary care providers in the area try to avoid taking on those patients at all costs. They hate patients, not hate patients, they hate caring for patients who come to them with physical dependence on high doses of opioids with unclear reasons for pain. It is technically illegal for a prescriber to prescribe someone opioids to maintain their addiction. You can only be prescribing it for pain, so it puts people in a really difficult position. That's why you have to have special waivers in order to prescribe methadone or buprenorphine. All right, so in addition to this increasing concern about heroin, we've got another entry into the illicit market that's making things worse than ever before. And I am very careful to avoid hysteria on these topics, so just know that I usually won't get hysterical, but I am about to. So heroin, it's kind of scary. None of us really want our family members using heroin, right? But fentanyl and carfentanil are much scarier. These are depictions of roughly equal doses of heroin, fentanyl, and carfentanil. Now, if you're familiar with fentanyl, it's also a patch or a liquid formulation that's used in the US, sometimes in hospitals or for people with chronic cancer pain. But that's not the kind of fentanyl we're talking about here. We're talking about powdered fentanyl that's either coming in as this powder from China and being mixed with heroin or just replacing heroin, or it's coming in as a precursor and being changed into fentanyl here in the US. There are a number of fentanyl analogs, including carfentanil, which is much more potent. Some are less potent. There are hundreds, and they're changing on a weekly or monthly basis. So increasingly, you don't know what's going to be in a bag of heroin that you purchase in the United States. Most overdose deaths in Ohio in the last couple of years were related to fentanyl as opposed to being related to heroin. So initially, fentanyls were thought of as an adulterant. Now, realistically, they're more of a replacement. You may even know that what you're buying is fentanyl, but if you have a severe physical dependence on these opioids, you're going to buy whatever you can get access to, and fentanyl many times is very cheap. So with the explosion of these in the last few years, we really first started seeing them, at least in Pennsylvania when I was there as a resident in 2013. We have seen a shift in the market even further away from prescription opioids and toward illicit analogs, fentanyl or heroin. So the prescription opioid line, which around 2010 was much higher than a number of deaths due to heroin or illicitly manufactured fentanyls. Now, it kind of plateaued, it kept going up a little bit, but heroin alone surpasses it, and all of these fentanyl analogs are the leading opioids that are present when people die from a drug overdose. And a tiny fraction of these are related to prescription fentanyl, like patches or injectable formulations in hospitals. So we now have a situation where at least twice as many deaths are due to illicit opioids compared to prescription opioids. But you'll still hear a lot of discussion about cutting back on prescriptions and making more abuse-deterrent formulations, and that's not necessarily a bad idea, but that's not where the issue is now. That's 5 years ago of thinking. All right. Sorry, I'm getting some lag here. All right, now we're going to put this in the context of youth. So, I don't know, how do you define youth for your pop-up institute? Or what age range you talking?
Yeah, 14 to 25.
Okay, good. So, if we look at diagnoses of opioid use disorder, which isn't just, oh, I've used an illicit opioid in the last year, but is a pattern of chronic maladaptive behavior around opioid use, we see that those numbers have been increasing among youth of various age cohorts, but certainly among 18 to 20-year-olds and 21 to 25-year-olds by far more than others. So college-aged youth are the most likely age group to have used an illicit substance in the last year, the last month, to have used heroin recently. So they are certainly our highest group of concern when we talk about opioids. Along with this increase in opioid use disorder, we've also seen an increase in injection use at early stages of opioid use disorder. So for a retrospective analysis that was completed to look at why are people who are young, why are they going into rehab programs? Are they injecting or are they snorting? That's changed a lot. When you could easily crush up an OxyContin or an Opana and snort a little bit, many people, a smaller proportion were coming in with any amount of opioid injection as part of their use. Now that's increased dramatically. So a 400% increase in hepatitis C has also accompanied that increased injection drug use. 15 states in the US do not allow clean syringe access. Texas is one of those states. So we are pushing people to an illicit opioid market that's more dangerous than ever without protection against infectious diseases. And they're injecting at higher rates than they ever have before. Drug overdose deaths are actually higher among people in like the 40 to 50-year-old range because of the beginnings of other underlying diseases like impaired renal or hepatic function. So our youth are not actually the highest risk for overdose death, even though they're the highest risk for active illicit use. But we have seen some fluctuation in youth risk for overdose deaths. And you can see it was really going up. We were seeing an increase in deaths in the pre-2010 timeframe. And for a period, it looks like cutting back on access to prescription opioids and making them harder to misuse, harder to crush and inject may have resulted in a decrease in overdose deaths for youth. But those numbers have started to tick up again at the same time that we've seen overall increased injection drug use and increased risk for fentanyls. All right, so now I'll stop talking about all the bad stuff and I'll introduce some solutions before our discussion. One of the solutions that I talk about a lot is naloxone. Somebody tell me what naloxone is.
Opioid reversal, overdose reversal drug.
Okay, an opioid overdose reversal drug. Can someone give me the technical pharmacologic term?
It's an opioid antagonist.
Antagonist, perfect. So it is an opioid blocker, and you could give it to somebody when they're experiencing acute respiratory depression. They're not breathing, or they're not breathing enough because they have too much opioid attached to the part of their brain that reminds you to breathe. And it will rapidly reverse those sedative effects and bring them back to life if you give it early enough. Naloxone only lasts about 30 to 90 minutes in the body. That's not always true. Really high-dose versions can last a lot longer. I'm going to hand around a high-dose version right now that we like to give out as part of our program called Narcan nasal spray. Full disclosure, they've given me a bunch of free medicine, and so I don't want to just pitch their version only. I want you to know that. Naloxone, it goes in, reverses the effect of that opioid, all of a sudden you're breathing again. There are several versions of naloxone, and there are kind of two ways that you can give it if you're a non-medical person. You can inject it into someone's muscle, either by using an old school vial and syringe, which is nice and cheap and has saved more lives than any other version, or by getting one of these Evzio auto injectors, which If you got great insurance, it might cost you $35. If you don't have insurance, they might try to charge you $4,000. Nobody pays that, but it's a weird, silly thing I don't understand. That makes me not like SEO very much. Also, it tells you exactly what to do, speaks you through the process once you open up the cartridge in an emergency situation, which is great, but it only speaks in English. In Texas, you never know who's going to find you. Not the best option. You can also do an intranasal administration, which a lot of people feel more comfortable with. I don't know about you guys, my mom finds my little brother down on the floor. I don't want her messing around with a violent syringe. She doesn't know what she's doing with that stuff. So I would love for her to be able to just squirt a little bit of naloxone in his nose. She could either have one of these improvised intranasal devices with a click-together pre-filled syringe and a nasal adapter, which is fairly inexpensive, or a Narcan nasal spray, which I'm handing around now. Not as bad as the FZO auto-injector, but you're probably going to want insurance if you're trying to get this one. In addition to giving people increased access to naloxone, which has been proven to reduce overdose rates in communities and actually increase people's interest in entering addiction treatment programs, we can expand access to user-driven testing for fentanyl or other ultra-potent opioids. You can hand out these test strips with instructions for how to use them, especially when people are injecting drugs. It's easy because they're already diluting up a solution of heroin or whatever they have in there, even cocaine, and they can dip a fentanyl test strip in. It takes a tiny amount of the drug, give it about a minute, and see if you find 2 lines, which confirms there's almost certainly no fentanyl in there, or 1 which says there is fentanyl. These test strips have been proven highly sensitive and specific for multiple analogs of fentanyl, but not all of them. It's changing all the time, and we need to provide that information to people. And initial surveys of people who use drugs have shown that if they had a supply that tested positive for fentanyl, they would use differently. In most cases, they would still use it, but they would use less, or they would start with a smaller amount, or they would make sure someone was around with naloxone. So we're working to do a little more investigation on this front too. These are the kits that we give out as part of our collaboration with Operation Naloxone, the Texas Overdose Naloxone Initiative. The Texas Targeted Opioid Response has purchased about almost $2 million of these products to give out kits that either contain the intramuscular vials or the Narcan nasal spray, along with fentanyl test strips and other response materials. On campus, we've done a few things to be better prepared for overdoses, like installing these naloxone boxes in every residence hall at the 24-hour desks, training every resident advisor each year during their orientation, training every UT police officer, and equipping them with FZO auto-injectors, which were donated to us. We didn't buy them. We've also trained more than 400 pharmacy students here at the college to be secondary trainers. And they've gone around and conducted overdose response trainings for UT students on and off campus, as well as distributed Narcan nasal spray in those trainings. We've got a website, operationnaloxone.org. We've got CE for prescribers, pharmacists, and social workers. We have resources for other campuses that want to be more prepared like we are. And please check it out.